Okay. Thanks, everybody. The patient's rights of appeal. This is this is something that's been near and dear to my heart ever since I met a couple of physician advisors in South Carolina about, I don't know, 8 or 10 years ago, who were taking advantage of the fact that the patient's rights of appeal are more powerful than the provider's right of appeal. And so I've really been trying to bake this into hospital workflows and other denial and appeal workflows because it is important, A, to assist patients, and B, there's power in here if you're not aware of it. So let's go over some hard facts. So 5 billion claims generated each year, and insurance plans deny 850 million of them. Well, that works out to almost 3 denials for every man, woman, and child in the United States. We know that that is, if you were to break these down, I would say all of them obviously involve a patient, because any healthcare transaction involves that patient. The claim, whether it's a pharmacy claim or a home health claim or an inpatient claim or an outpatient infusion therapy claim. The fact is that it's such a large problem today that we seem to be treading water and drowning. At the same time, we're not really giving the patients their due process for making sure they can appeal or assist in that problem. One thing with patient denials, whether it's a prior auth denial or any other type of denial, we know through years and years of study that patients will experience worse health outcomes because of the delays in care. And so think of how upset you've been given a diagnosis, a test has been ordered, and now the insurance payer or the plan administrator comes back and says, well, we don't think that's medically necessary. So patients are clearly stressed, and some will dig in their own pockets to take care of that when that's not what should happen. Providers also experience the same emotional and financial stress. It's one of the leading causes of physician burnout nationally. And so even though 94%, and we've just studied this through many different organizations, but one we're particularly, we believe is very credible is the Kaiser Family Foundation. 94% of denied claims are medically necessary, but patients only appeal 1% of the time. Now that came out of an ACA survey back in 2023, but we don't think it's changed very much. Now the 1% that were appealed, 44% of those were overturned. That's pretty stark. Now what's interesting is I can tell you that the insurance payers are absolutely aware of that 1% statistic. Absolutely. If I were them, I'd know, oh, we've created such a hassle factor and such an absolute Byzantine labyrinth of rules, legalese, medical terms. No wonder they're not appealing. So all the patients that we have, and we're going to talk about today, we're probably going to talk more about due process and rules than we are about clinical. Because if your clinical argument is sound, there's no reason that patient should have been denied. And it could be a diagnosis from their PCP, from a specialty physician, but all patients are legally protected. If you were to go state by state and agency by agency, you would see that most of the language actually talks about members or patients. It doesn't necessarily address providers as much as it addresses patients. And so the many, many years that we built up these protections for our patients aren't taken advantage of. And the fact is they do need help from the experienced team that is helping deliver their care. It's also the experienced team in appeals. So we recognize that if we can align the incentives for patients and providers together, for patients to get the care that they A, need, and B, is covered, that providers can help essentially by assisting or directing them to areas that will help them, even giving them an appeal primer, anything to help them join in the fight against these wrongful, egregious denials. So these look like a plethora of learning objectives here on this slide. And I'm not going to read them directly to you, but there's clearly a very, very important thing that's not happening, either at the point of access or the physician's office or in the clinic or as they're registering for the hospital. Big one for us is that patients do not know what their benefits are when they walk into the hospital, whether it's through the ED or any other area. They don't have a detailed view of what is covered, what's not covered, what are the rules around that, and if in fact something is denied wrongfully, what am I to do? And so I know, and I can tell you for sure, that most hospitals and health systems and most physician practices do not ask that patient for their coverage document. I think this is a mistake. I think if we could bake into every interaction the request for the summary plan description, things would change. Things would definitely change. And so there are different laws that are available and apply to the patient's care, but it's different by plan type. So it's almost deliberately non-standard, right? So you have many different plan types. We'll talk about all of those as I get in here. And what exactly am I allowed to ask for from the payer or the third-party entity? Think Evacor or any of these other third-party companies that say, oh no, that doesn't belong in the formulary. You're going to have to use this drug, right? And the patient will, wait a minute, my doctor didn't prescribe that drug. So these decisions that come from these supposed clinical oversight teams on the payer and the side, they're not always right. And so we know that also there's information that you can and should demand from these folks and how to file complaints against if they're not really living up to what they are supposed to be compliant with. And so one of the things that we don't address when we deal with the appeal process or the decision process is, when are they out of compliance? And so how can a patient file a complaint against the payer with the right agency, the right department, and even with their own employer? And so the other is, how do I actually say, look, I need to make this more efficient? Can I put together demand letters and appeal letters that telegraph the patient's intent to pursue, no different than you should be telegraphing your own intent to pursue as a provider? So we'll go over some of these. If I miss some, I tried to put as many as I could in here. The first, I think, that we really have to understand is the difference in plan types. And we're going to go through these. And this is to me, this is the primer, right? You have to understand what plan type it is. And the interesting thing is, I might see the plan's name on the UB04 or even on the remittance advice, but it's not telling me, oh, this is an ERISA plan. Oh, this is an employer-sponsored plan. Oh, this is Medicare Advantage. Now that might come through. But the fact of the difference is every one of these plan types have different appeal processes. And understanding that and helping your patient understand, hey, here's the process for your particular plan. So I challenge, I don't know how many people are on the call right now, but even within your own plans, within your hospitals, right? You all have insurance through your employer right there at the hospital or health system or whatever large organization you're tied to. These are ERISA plans. These are self-funded by the health system or by the hospital, and they actually, where the hospital is the plan owner. Your employer is the plan owner. Which appeal levels apply? how many levels of appeal are commercial, ACA, Medicare Advantage entitled to? We all know Medicare, because through the RAC program, we all learned that 5 levels of appeal, all the way up to the ALJ, beyond the ALJ, 2 more levels, right? What are the timelines? Because the timelines differ by plan type. And so building out a matrix, and we built one for you, is important. Understanding what does the payer require or the plan administrator require for the patient or the patient's authorized representative to represent them, right? Is it a designated reviewer? Is it an authorization of representative? What is it? Well, the very fact that everybody should know what a 1696 is, that's a CMS authorization form where you can represent that particular patient. And so also, when can an external reviewer or government agency intervene on my behalf as a patient? I need to know who, where, how do I notify them as that patient? We've also learned that there are very payer-specific authorized representative forms. And I would say about 10 years ago, when I started talking about this, I said, look, take the assignment of appeal rights and embed that within your consent to treat. Now, I've had many clients over the years begin to do that, right? It's right at the front. And large systems and small systems finally got the idea that, hey, let's make sure we get the patient's authorized representative rights for appealing, A, because patients have more appeal rights, and B, it's really a service to the patient. If hospitals and health systems truly believe that the patient is at the center of why they're here, we have to make sure that when there is a hurdle thrown in their path to get care, we can assist them in some way, shape, or form, some process to do that. So each plan type has different requirements and different forms. But again, it's not rocket science. And organizational structure and a workflow, make sure I have the right form for the right plan type for this patient of mine. The additional thing is you're fighting to get their benefit covered, which means hospitals and providers can get paid if you win for the patient. And this is even if the hospital's appeal rights are exhausted, we can help the patient win. Now, there's some rules around like waivers of liability you have to think about, but that's an important thing. So the waiver of liability, that applies certainly at CMS, and some other forms may or may not have that in there. So the waiver of liability clause simply states that I won't go after the patient and collect that if the payer upholds the denial. So when you actually represent them, you do the work, or if they do it themselves, once again, this waiver of liability, if you're their representative, you really aren't be able to go after them. And I don't think many organizations do. That's still one of the challenges between, do I go after this patient and their payment if in fact we've done nothing wrong, they've done nothing wrong, but the payer upholds the appeal. And so it's really, really crucial to understand waiver of liability. It's embedded right here in this 1696. We would fill these out for virtually every hospital that we were writing a RAC appeal on or a Medicare traditional appeal. We use this form all the time because we do represent, and we actually indicate that we represent the patient. This has to be signed. If you're going to use it, this is something you should become familiar with. I would be absolutely astounded if it's not already an electronic document in Epic or Cerner or Meditech or whatever EMR you're currently using. So this representative form, it really makes a lot of sense to look at the regulation requirements, look at the form, understand how they're done, and make sure you set it up so that it can be filled out automatically, or it's all ready for the patient to sign by the time they get there. So these consent to treat forms, they're fine. That's good. Okay. The gold standard for sure is executing the payer's authorized representative form or that CMS 1696. Now, when you go to the payer's authorized representative forms, you know what you're going to find, right? You're going to find a link you have to go to, right? So what we've done, and we think it's a smart thing to do, is go to those links, download every PDF for every state that you work in, and make sure you have the right form. That absolutely. One of the big problems with the right documentation is you're submitting the wrong form with it, or the patient is. And so you can go to any one of these and pull up that information. And I don't think it's, I can't do it here. But again, are they state specific or not? So United Healthcare has plans all over the country, multitudes of plans within that state, different types of plans, and those plan types are going to vary. The payer absolutely sets it up so the patient finds it really hard to figure out which form to use. And so I believe that the provider is best suited to assist the patient in getting the documents they need to effect a due process appeal for their denied access to care. I put this up and copied this just as I laughed so hard when I looked at this is the United Healthcare portal, as I was looking for the authorization and review forms. This is their, I looked at the plans, 1,283 different pages related to plans, right? Location, service area, policies and protocols, 1,449. I just couldn't stop laughing. I'm saying, wait, I'm just looking for an authorized representative form. Imagine a patient having to go through all of these and try to figure out where to get the right form to fill out. We should have it ready for them. This is great leverage. The patient's right to obtain information from the payer. Asking the payer for the information is really required. So if you say, I represent the patient, I need a copy of the summary plan description or the insurance policy, and making sure that I get that within the time frame designated, if that particular appeal is out there. And then if you see any adverse benefit determination, or I think they also call them organization determinations, that's really going to trigger the patient's right to ask for that information. They need to make sure they understand the denial letter. We know that many denial letters that are sent to the hospital are actually addressed to the patient. They're copies of what the payer has sent to the patient because they are required to notify the patient if they're denying access to care or procedure or treatment. And so the patient has this denial letter, has no idea what to do with it, calls their doc, says, what do I do here? And the doc says, well, you need to file an appeal. So that's not enough. That's not enough. So the payer also has to produce any relevant information that is related to that denial. And so free of charge, all documents, records, emails included, other information that was relevant to that decision to deny the patient's claim for authorization or coverage. They are required to produce this. But do patients know how to ask for it? No, of course not. Do providers? We know well enough all of the different tricks, hassles, whatever it is, that insurance plans and plan administrators put in our way. If we have a hard time doing it, and I still think it's really not, it's not down to an absolute science yet on appeal response and appeal management, but we're getting there. Their failure to provide the documents costs them money. And so they must require this information or produce that information. No different than if you're going into a legal case and you're doing discovery to make sure that happens. It sounds complicated, but it's not, as long as you have a process set up within your own organization to assist the patient to do this. What do you consider relevant documents? Well, obviously the medical record, but anything that the payer relied upon in making that benefit determination. See, there is or the denial, right? Anything that was submitted, considered, or generated in the course of making that determination. And a statement of policy or guidance concerning the denied treatment. They have to say, what is the rationale? Why was it denied? Is it specific to their diagnosis? But something that says, hey, it's not just on my, I don't believe you technically did things wrong. They do have to say, what is the policy that led to us, the payer, making this decision to you, our beneficiary? Oh, I think I already did the slide. Good. So this to me is really important, and you might, this to me is one of the biggest takeaways. It's the summary plan description, summary plan document. And the reason I say this is, we'll go into this in just a little bit, but the largest by far group of insured or covered lives is in that ERISA self-funded employer plan area. Almost 170 million covered lives are in there. And so many patients come in, don't know their rights, don't know what's covered. And I would challenge everybody on this call, do you have a copy of your summary plan description? Have you ever asked for it? It's one of our survey questions. And do you know what it does and why it's important? And so, do you know what your covered benefits actually are? Most people don't know. Everybody's one day away from being a patient. You're an employee or a member or a beneficiary today, but tomorrow you could be a patient. Nobody knows except for God. And so the fact is that we need to be prepared. So I believe having the summary plan description and making sure that that is not behind the payer's firewall, which frankly it is. We don't have easy access to that. We as the provider or we as the patient. We actually have to go find it. So it's not like it's sitting in a desk somewhere. I believe this is one area where employers and even the federal government can go to large plans and say, look, you need to make this available electronically for them to look at. It should be in my chart. You know, wouldn't that be nice if it's in the Epic My Chart? So they have to know exactly what's covered, exactly what's not covered, and what are my rights if something is not, allowed. The other thing is the plan document. This gets, especially as you get into larger cases where there's a significant amount of dollars that might affect that particular plan's stop loss or some other high dollar catastrophic coverage. Absolutely, you should be requesting the plan document on behalf of, as an advocate for that patient. Patient could be a NICU baby that's been there 150 days, but any high dollar, high length of stay case, you should be asking for the plan document on behalf of that patient or that subscriber, because obviously the subscriber is the mom or the dad. It's not the baby in the NICU, right? And so this legal blueprint is exactly what's used by the TPA. If there's a discrepancy, the plan document and the governing law typically prevail over the SPD. So you, as somebody who can help the patient understand the relationship between these, you should be requesting this document for high dollar cases, high length of stay cases. Same with the summary plan description, because the odds are something's going to happen at the end of that case. 1 out of 5 are going to be denied in some way, shape, or form, either pre-claim or post-claim. So pre-adjudication or post-adjudication. So this is really important information to have. If I say made it a bullet point, that summary plan description is something you need to understand and ask for. We know, at least in our organization as advocates and somebody who's studied federal law, state laws, plan documents, patients have much greater rights of appeal than the providers do. And so you as providers can use this particular facet to your advantage. This is where the hidden power is. And so understanding that plan type, and again, you're all very schooled in this, but it's the first and foremost important step because rights vary dramatically by plan type. And to us, and I really believe this, and probably to you, going all the way means fully advocating for the patient's rights, which means you need to understand what the patient's rights are. The patient will benefit and you will benefit. So it's really a win-win for patients and providers if we spend a little more time understanding what their needs are when it comes to a denial or not getting access to care. So I talked earlier about the largest bucket, right? This is the largest bucket of covered lives that you deal with in a hospital setting. And it's all about ERISA, which is frankly it's a big law, lots of big regulations, but we're only concerned with the regulations that talk about the health benefit. And so once a hospital has ERISA rights from the patient, you can use this to oppose any number of organizational determinations or findings, denials, recoupments, audits, really. So anything governed by ERISA, and I'm just going to repeat this to you. This includes your own hospitals, the ones you work in, the health system you work for, university, community, it doesn't make a difference. They're all typically self-funded plans, and they're subject to ERISA, and they're the plan owners. And so if the plan documents detailing all the coverage in terms of the plan, if they're the governing documents, right, you need to make sure that they're playing by the rules. And I want to automatically understand when they're not playing by the rules. So this is just a quick snapshot of an ERISA funded plan. So employers, let's just say Johns Hopkins Health System, right? They fund the claims. But United Healthcare is a third-party administrator. Well, not United, because United and Johns Hopkins don't get along anymore. Let's just say Blue Cross and Blue Shield of Maryland, Care First. They're the third-party administrator. They're just a processor, right? But federal rules, not state laws, govern these particular appeal rights. So don't go to your state, don't go to your Department of Insurance. It doesn't do any good. And so if you have an ERISA plan and you're being denied access to care, or your patients are, request a summary plan description right out of the gate, okay? Just right out of the gate. And with these processes, there's a level 1 appeal, right? The timeframes are listed here. There may be a level 2 appeal, but every self-funded plan, the patient has a right to external review. And this was part of the Obamacare legislation that was started in 2010, is that it's not just good for self-funded plans. All employer-based plans are required to have some right to external review. If you're not giving your patients access to that or informing them you have access to an independent review, they're not going to know, because they're not going to know how to follow the rules. And so part of it is helping the patient help you make sure the plan follows their rules. The next, or one of the largest covered lives, the volume of covered lives, are employer-sponsored commercial plans. And they differ obviously from self-funded plans. This is back the old model where we buy insurance from the carrier actually carries the risk, and they are in fact regulated by each state. plus the ACA requirements, because commercial plans can also be delivered through the ACA. So the good thing is that the state law can be stronger than ERISA. In some states, we've learned, we work in probably about 40 or at least 40 states. And that state by state, some seem to be provider and patient oriented, and some tend to be regulatory business oriented, government strongman. Florida doesn't have the same rights of patient appeals that California does, quite different. So, but the state insurance department often has an ombudsman or a helpline specifically for patients and patients' representatives. So they can intervene when insurers don't follow the rules, but you have to know what rule they broke. You want to document that, dialogue it, get it in there. Again, 1 to 2 required levels of appeal, very similar to ACA rules. There is an urgent request. So if an urgent request for service and the patient obviously could be harmed in some way, shape, or form, if something isn't done, those 72-hour urgent requests, they have to get back to us within 72 hours. If it's a pre-service denial, they have to get back to us within 15 days. Post-service, 30 days. So if we put in, right, they've denied something, and we put in an urgent request for review or appeal, they have to respond quickly. This is probably the #1 broken rule, is they don't respond in time. Often there's a state mandated external review. We've done a fair amount of work in Tennessee, and specifically for Medicaid recipients and managed Medicaid, because managed Medicaid is required in Tennessee. There is an external review specifically conducted and paid for by the state. I do think it's one of those, the loser pays setup, but you should be helping the patient take advantage of that, right? It is binding, and so it's a great opportunity to help the patient get through this particular problem if it's upheld at the final level. The marketplace plans, I really hope they survive. You know, this whole brouhaha about the doubling of premiums, you're going to see a lot of people leave this marketplace plan for sure. But all these fully insured commercial plans, really, these protections apply fully to these patients. Again, at least 1 level of appeal and absolutely external review. Now, patients can also call a specific government call center or state consumer assistance programs, because most of the ACAs are delivered through, you know, some cooperation with the state. And so there are patient available support. And I say patient available, I also mean you as the patient's authorized representative, even though you're also the provider, have an opportunity to take advantage of that. You're going to have to prove that you're the representative, of course. And I know that the payers will really make it hard for you to do that. And so be ready to prepare to send the authorized representative form at the same time you send the appeal or anything else. And so clearly Medicare Advantage plans, we all know what these are, the fastest growing scourge in healthcare. I'm sorry if there's any payers on the line here, but really it's just a private, privately run Medicare. So the appeal rights are supposed to be strictly regulated by Medicare, but we know that there have been, you know, plans step out of bounds. They step the boundaries that are there. So they'll take any advantage they can. And so the plans, if they're in fact going to do an ABN or a notice of denial of medical coverage, they have to provide the patient with a denial notice. So this is important. Very important. So if it's specific specifically related to ending a hospital stay, ending a SNF stay, ending an IRF stay, that this organization, the VFCCQIO, specifically handles those immediate appeals. And those are, you need to be set up and ready to appeal for that patient. The patient has better rights than you do, and you are appealing on behalf of the patient once you send in one of these QIO requests. Similar patient appeal levels, level 1, plan reconsideration, and then from there, if it's upheld, some MA plans offer level 2, but you got to file quickly, right? There's standard decision times, 14 days for medical care, denial 60 days, an expedited request, which might be acute to rehab, where you really need to get this stroke patient into the IRF. It's the only right setting for them. That if it's an NA plan, you're going to go to an ALJ, but they will quickly make a decision on that, okay? The independent review entity is involved at level 2. Level 3 is an ALJ. They call it a hearing, but if it's an expedited request, things move very fast when you get these to the ALJ and you're trying to get a patient into the proper level of care, not just because the doctor wants them there. Traditional Medicare, I was chatting with my brother just the other night and explaining the difference between Medicare Advantage and traditional Medicare. And if anybody, by the way, this is just an aside, if you haven't seen the John Oliver last week tonight part on Medicare Advantage, Google it. Okay, this is just one that you'll laugh, you'll recognize how wrongful it is, but he does a great job in explaining the challenges with Medicare Advantage. But thank goodness for Medicare. They do everything right typically. I'm a little bit concerned about their interest in this WISER program. But these timelines, this appeal process, you need to help your patient, because let me tell you, they're not going to know how to walk through this process. And so if it's a primer you give them, if it's assistance you give them, if you act as their advocate, just be prepared to streamline all this all the way. Their rights, and the ALJ absolutely is much more prone to listen to a patient explain than necessarily the payer explain. Medicaid, state by state, right? There are different. There are certain rules under CMS that are governed, right? And the states can't be any more strict than the federal rule. Actually, they can be more strict, but no less strict than the federal rules and the appeal rights. So states may actually give Medicaid recipients greater rights than CMS does. And so with patient appeals for managed Medicaid and traditional Medicaid, we all have heard the idea of a state fair hearing. So there is a process, but again, the patient needs to be guided and helped through this process of attending a state fair hearing. So it's they're just not set up, I think, from a comprehension perspective to understand all the steps they have to go through, A, to be a Medicaid member, and then B, if something gets denied, what do they do? Most of them do nothing. So that's the challenge. This is a grid we put together. I think anybody that downloaded this can have this as one of their slides. You can download this. But this is just a quick primer for each of you to present to your patients if necessary. But again, imagine trying to explain all these different rules to your patients or your patients' caregivers, as opposed to, look, we can assist you in this effort to appeal on your behalf. Payer malfeasance. I'm going to take a quick sip here. Sometimes I worry about using this term, but I really do think it's payer abuse and payer malfeasance. I've been saying that in some of my correspondence and some of my presentations for a long time. But is it intentional wrongdoing? And the key component to determine what malfeasance is they've done it on purpose and it's illegal or morally wrong. The or is what got me, frankly. They know what they're doing and it is morally wrong. And so I can call it malfeasance, and that's what I think it is. Strong language, maybe no, it's not language that the managed care director wants you to use with your payers, but the patients absolutely consider it a wrongful denial. And so sometimes, and we've received these back, the payer, even though I've created this provider assisted member appeal, payers will come back and say, oh no, that's a provider appeal. We're like, no, it's a member appeal. And we're using the member's rights. So they don't call it a denial, they call it a benefit/coverage determination. Well, if it looks like a duck, walks like a duck, and quacks like a duck, it's a duck. A denial is a denial. And so we're really kind of at their mercy of what they interpret these Byzantine rules to be. The Part C plans. If the payer doesn't automatically forward the upheld denial to the IRE, that's to your benefit, right? And it's wrong. So it's definitely wrong. Make sure if you and when you, I'm not going to say if, because I think everybody needs to jump on this bandwagon. When you set up a member appeal or a member appeal process, don't forget to put right at the top of that first page, member appeal. Whether it's being submitted by you on their behalf, or you give the patient a template that says, here, fill this out. I'll give you the medical record, right? I'll help you with why it's clinically necessary, but here, take this. Because who submits it? If the provider submits it on behalf of the member, do you think the payer recognizes that? No, it's going to the member appeal services unit, right? You want to make sure that's where it goes. It's a different address on the back of the card where those appeals are. Different addresses, different PO boxes, the whole works. So you have to make sure you know where it goes, and make sure you put member appeal right at the top. So I apologize for these bullets, but so this is just a case study that we learned about with acute to rehab member appeals, and 90% success rate to date with federal ALJ determinations. What that means is they've already, determined this is going to go to the ALJ, and so we're going to do an expedited review, and we're going to get that information to the ALJ based on our recognition that the patient needs to be in a step-down level of care, not a SNF and not at home. So we directly communicate that to the insurer, and if they do that, that's fine. But all these patients were really transferred to a health system-owned rehab with a concurrent urgent appeal on the patient's behalf as to what their entitled benefits are, which include necessary rehabilitative care. So, and these are patient appeals. These are not provider appeals. These are going out as appeals that the patient, right, is doing. Now it's submitted with the help of that provider, but it works. And so I would urge you to a 90% success rate on MA plans. Templates and tactics and technology. So we're going to talk a little bit about this. Templates. So I've said before, one of the most important things to do in moving forward in being a patient advocate as a provider or a patient advocate as a caregiver is a demand for that summary plan description. Now, This only applies to employer-based plans, but it's by far the largest commercially set of covered lives in the country. It's not the same as an MA plan, but does the MA plan participant also have a right to demand the summary plan description? Because, well, it's supposed to be Medicare, right? But they signed a contract with the MA plan. They've signed a contract with United or Humana or whomever is administering that Medicare Advantage plan. And so the contract between the patient and the private payer who's managing Medicare is A, hidden behind a firewall somewhere, and B, I can assure you those Medicare Advantage recipients do not know what's included other than, well, it says it's all Medicare, right? Plus things. Well, the appeal rights are different. The process is different. So making sure that you understand on behalf of that, let's call it that Medicare Advantage beneficiary, understanding what United or Humana or Cigna or Blue Cross says their particular appeal rules are. Because the only thing that's similar, frankly, are what's covered and the benefits they're entitled to. The administrative rules, different, not the same. And so can that third-party plan administrator take advantage of Medicare Advantage recipients on the appeal and the levels of appeal side? And so we think it's important to understand what the differences are between those two. As far as filing a member appeal and creating a member appeal, part of it is, look, how bold are you going to be? Are you doing it on behalf of the member, or are you handing the patient this information? So being bold and strongly disagreeing, and essentially, I want to call it firing the first shot across the bow that you intend to pursue till the cows come home. Because essentially, if it were the patient writing a letter, the patient would say, I'm going to pursue you until you give up. And being this strong of an advocate really means getting your dander up on behalf of your patient or your, essentially, yourselves, that you can represent the patient. So part of, once again, making sure you call out and saying right in the letter, this is where I'm going and this is what I'm going to do. Thinking as a demand letter rather than, and especially if it's a patient. The patient does need some assistance understanding why clinically should I have been permitted this care. And so all that information, it's not going to come with the patient's knowledge. They don't know that. You absolutely know why that care was necessary for the patient. You can be able to share that with them. You can work with them so they can develop their own anger, bot and send it off to everybody they need to send it to. So member appeals and member appeal templates should be built out so they're understandable by your patient and that they're actually tied in with your processing of their medical necessity of why it's there. Tactics. This is a bit harder to really get across because I think there's various reasons why hospitals do things and payers do things and why patients do things. We're big believers in what we call the tattletale strategy, excuse me. Tattletale. But it really is the tattletale approach. So you can name on one hand, maybe two hands, who does the payer not want to hear from? They'd rather not hear from the patient or the patient's family. They'd rather not hear from the patient's employer. They'd rather not hear from the state, whether it's the Department of Insurance, the Ombudsman. They don't want to hear from CMS. So Part C oversight is a big deal, and nobody's using that. Patients don't even know it exists for their Medicare Advantage plans. They don't want to hear from the Employer Benefit Security Administration, who oversees all of the ERISA plan rules and regulations. They don't want to hear from the OIG. What's interesting, they don't want to hear from their compliance department, because if a patient recognizes, or you as their advocate recognize they've broken a rule or they've broken rules, you need to get that to their compliance department as a part of your process. And so every one of us is really engaged in trying to ensure that the patients who are at the center of our journey in healthcare are getting exactly what they need as we've so judged. We, the providers, determine what's necessary for the patient. It's not the payer or the payer's medical staff that should be deciding what's right for that patient. And certainly not the technical denials that we typically run into. So we need to all stand up for the patients. And this tattletale strategy, I can assure you it works. But part of it is baking into, who do I CC on this particular appeal and why? This is a bit of a challenge to think about. It's about the employer-based plans and whether or not they're going to go to their human resources department and say, you know, United is not being fair. My daughter needs that particular asthma drug, and that's what her doctor says. And so going to your employer, who is actually the health plan, but they're not the health plan administrator. So every one of your employers, I'm just going to say everybody, 95% of the people on the call, I'm sure, are employed within a healthcare setting in some way, shape, or form, mostly hospitals and health systems. But your own employer, whether it's Michael Dowling or Gene Woods or any other CEO, your employer has a fiduciary duty and responsibility to ensure that the plan administrator follows the rules as laid out in the plan document and the summary plan description. And when they don't, right, it's up to the patient to bring it to their employer's attention and ask for assistance in HR. I think some employees are skittish to do that, but I can tell you one particular, and it absolutely blew us away. So we've done some pro bono cases in the past year for patients directly, without making sure we had their rights of appeal, of course. And I will tell you that two of the patients were actually employed. One was a 32-year nurse employee of a large health system out west. She had literally no idea that this large health system was actually the plan sponsor. She thought it was United Healthcare or Aetna. The other healthcare employee was a chief medical officer. And this chief medical officer's wife had an absolute need to get a cervical procedure done, or else, she was in danger of paralysis. And he also did not know that the hospital itself was actually the plan. And so we walked him through, hey, this is what you need to do. Yeah, I'm going to ask for a summary plan description. Get us the summary plan description. We look through it and recognize the benefit that the plan administrator denied is actually in the summary plan description. Another horror story, And this is one where a health law attorney is very involved, right? Her daughter is a 22-year-old college student with a congenital lung disorder that requires expensive drugs, expensive treatments. They have insurance. They have two insurances, right? Yet the plan administrator denied that young lady access to life-saving care that she needed to rule out and to stay away from a lung transplant. So it took months and months and months. But even the health plan attorney wasn't completely understanding what the summary plan description was or how it's applied and how we could go back to her husband's, because her husband actually had the insurance, her husband's employer, and begin to argue that they have not followed the right things. So it's definitely beneficial to the employer that they're made aware of denial behaviors that are occurring through their plan administrator, their impact on their employee, or their family, because it's typically somebody in the family that needs it. Technology, this is a short one here. So years ago, we put into our system the ability to craft at the same time we're crafting our appeals for our provider clients, that look, we need to put the member appeal track in here. And so if in fact the provider might have had a final uphold, but the member still has light in their appeal process, let's go that way. Now, the other challenge is, hey, why don't I create both appeals at the same time? Virtually the only difference is going to be in the template and where it goes. That's it, because you have the same clinical arguments and the same legal arguments with some differences, I think, in how you would phrase a member appeal versus a provider appeal. But the fact is, you're building systems internally, whether it's Epic or Cerner or whomever is going to be taking care of your appeal processes, that don't forget to bake in and build a member appeal process like we've done. And so, like everybody else in the world, we also know, we're not, our heads aren't in the sand. And so we've been experimenting with AI as a, quote, force multiplier for the last 2 years at least, and recognize that many health systems out there are believing that AI can assist them. It's a job aid. And I think our very well-tested viewpoint is that AI LLMs can't be completely trusted on their own. Agentic AI still needs a way to go. Generative AI, if contained, right, can absolutely work on behalf of generating patient appeals, even provider appeals. So part of it is using AI as that force multiplier, because you're all sitting back saying, oh my gosh, I can barely get to my own appeals as a provider. Now I have to do patient appeals? Well, not necessarily. So I think there are some solutions coming down the pike that really talk about efficiently and cost effectively appealing denials specifically on behalf of patients, right? Patient-centric appeal process, patient-centric delivery systems. The patient is supposed to be at the center of all this, okay? So using AI as that force multiplier, that's a technological advantage that didn't exist 18 months ago, but now it does. And within our ability to serve these patients, the 1/5 of patients that are being denied pre-claim adjudication or post-claim adjudication, that we can step in and serve them. So, all right, that's my presentation. I open to questions and comments and thoughts We'll take all the advice we can get because we're here to serve as patient advocates as well as provider advocates. And so I'll open up the floor. Eric, if you could, you might want to ask the questions, but
Yep.
Okay, so what exactly do I do to make sure it's just me on the screen? Stop sharing or?
Yeah, yep, you can do that.
Okay, good.
There you go. Yeah, we had a number of in, so we'll just kind of fire away.
Sure.
One, the denial letter often states that the patient is not financially responsible. An AOR is needed to use the patient rights. So how do you get patient buy-in during the appeal process?
Well, if the patient has no financial responsibility, what other, let's call it, what other options do we use to ensure, to see if they can do this? If they are signing that AOR form at the point of entry into your system, right, you're already signing a waiver of liability on behalf of that patient. And so you already know that they're not going to be held financially responsible. So you may have hold harmless claims in your contracts that and frankly, this is one tactic that the payer uses to inform the patient. Why do you need to do anything? You're not on the hook for anything. Part of it is the patients who recognize that they are part of the community, just like hospitals and healthcare workers believe that they're part of the community. And so it's doing right by the hospital that patients will allow the hospital to appeal on their behalf. Now, there may be some, if the patient doesn't have any financial liability and going to, for government appeals, that's one thing. So that is something you got to perfect. But certainly on the commercial side, on the ACA side, on MA side, the payer may tell the patient, you don't have any financial responsibility. But frankly, the financial responsibility begins after they're discharged and they realize it was only outpatient and now you're not going to pay for my SNF or my IRF. So a payer denying a level of care where subsequently the patient is at risk in the future for additional outlays is something you have to consider. So it's tricky, but it can be orchestrated in a workflow and a flow chart that says, what do I do if the payer sends this letter to the patient that they're not on the hook for anything? You need the patient to join you in righting what was wrong.
Great. Next question. We recently started getting AOR forms for all of our managed Medicaid or Medicare patients, but would you agree that we should get that for all patients?
Yes.
Require it.
Well, I think you can require it from the patient, but frankly, building a library of AOR forms by your top 10 payers, not terribly hard. Not terribly hard in today's world to take that PDF and embed it right within Epic or Cerner, right? So you have the ability to make this part of your access process or discharge process, either way. But the bottom line is you need to fill out the paperwork to help that patient. It can be explained to them when a patient's discharged out of outpatient care and they say we're not going to make you inpatient and you have to do this I think it's the Medicare release form where they have to sign agreeing they know that once they're made an outpatient the charges may accrue, right? And so when you go from inpatient to outpatient level of care while the patient's still in a bed, I can assure you they're going to have some post-discharge challenges from that payer on what they're entitled to. So I'm a big believer in saying, look, just do it once. Get the forms out to your people at one time. and they should be embedded in your system. It should be digital. It should not be paper. Paper is a backup, but digitally get these things and put them in play.
Okay. Next one. Most of our patients' commercial plans are self-funded from an employer.
Yep.
Is the external reviewer for self-funded accounts usually the employer?
No. So within the plan itself, and again, this is another thing that the summary plan description will outline, that the independent reviewer, are you saying is it quote hired by the plan administrator? That might be the case, but in fact, it's independent for a reason, and usually it's one of those setups where the loser pays. But the fact is that all patients are entitled in an ERISA plan an opportunity for external review. We'd like to believe that that external review is in fact impartial, and so I move forward with the idea it is impartial, but it is binding, that external review. So your best arguments that you made in that first level appeal as a provider need to be presented just as strongly on behalf of the patient in that external review. So I really think that the challenge is patients need the opportunity to go to external review because there are going to be some wrong decisions made. It's wrongful what these plan administrators are doing. I'm not saying it's wrongful what the plan's doing, but the ones operating the plan, which are really the plan administrators, they're not playing by the rules. So yes, I think you should be going all the way for your patients, right? No different than you're going to go all the way making sure they get the best available treatment to serve them. You need to get the best available advice to help them get the services they need. So external review is a good thing, not a bad thing.
When does the waiver of liability come into play? So if prior authorization is denied and patient has already gotten the care, would that mean the provider can't go back and bill the patient?
Yes. If you are in fact going to represent the patient to get that care, in fact, that covered benefit taken care of, the answer is yes. You must sign a waiver of liability that you won't collect from the patient. But part of that is it's really a member appeal. And if you win the member appeal on behalf of that patient, you will get paid. You'll get paid by the insurance company, but not the patient. Now the patient may still be liable for their deductibles and their copay. It just means you can't, the part that the allowable that the payer didn't pay, that's the part you can't go after. You can still collect your copays and deductibles, even when you they sign a waiver of liability or you sign that.
Okay. Okay, next one. A little long here, but we can. All right. So our legal team told us the AOR form needs to be signed by whoever would be representing the patient if it went all the way to the ALJ. Question is, does that mean it has to be a legal representative signing those forms, or can the nurses continue to write and submit appeals, and then if it goes to the ALJ, our legal team could step in?
So the answer is yes. You can fill out the AOR form at any point within this, but to get into the ALJ, to get into that 5-level appeal process, it's typically the AOR is required when you go to the ALJ. So in instances prior, I don't believe the AOR form is required to go to the first level appeal, the reconsideration or the redetermination level. But when you get to the ALJ, yes, it is required. So I'm like you. Let's get the patient appeal out quickly, right? Make sure we know the rules and what they're going to be held to, and that if it gets to the point where you've been upheld twice whether it's through the traditional Medicare process or the IRE process that's set up for MA plans, you have the opportunity to go all the way. But the AOR form is definitely required to schedule a Medicare ALJ Medicare hearing. That, I believe, is even true for urgent reviews. You have to get the AOR form done before it gets to the ALJ. So I'll double check on that, but I'm pretty sure that's the case.
Okay. Any advice with or for pitching the utilization of patient appeal rights to the C-suite?
Oh,
Getting buy-in from, yeah.
Yes, I have advice. I do, plenty. But the first thing is that everyone in the C-suite will, if you ask them, will recognize that the most important relationship with the hospital is the hospital's relationship with the patient, right? It's in writing everywhere. It's in your mission statement, okay? It's in every mission statement. And so if you throw back the language of the mission statement, say, we're doing all this on behalf of the patient, but this is where we're falling down, we can help, right? And it should be our God-given responsibility to assist this patient or this patient's family that's in the middle of this steaming tar pit of a mess called healthcare denials. I just made that up last night, steaming tar pit, because that's how I think of it, you know. So no, I really believe that you approach directly your leadership and advocate for your patients with them, and that they should understand. They know the problems that denials create. You've seen it, you know, the catalyst was a couple of years ago. It was a terrible situation, which really made people stand up and listen to this. But everything I've read across, from Becker's to healthcare executive to health affairs, are that this leadership is tired of deniers, delayers, and don't payers. Bring it back to them and say, this is one area we've fallen down. We are not, only 1% of patients appeal their patient denial. I mean, come on. If you can convince or set a process up where 40% of your patient appeals are generated, imagine what that does, A, for the hospital, and B, for the patient and the patients that need it. So yes, I think you should be going to your C-suite and raising this as a real, it's a patient care and patient quality issue. When we know that delays in care and that really create problems for the patient. Some patients won't even go. It's not just delaying care. They won't fight it. They'll just, okay, if I get sick enough, I'll go to the ER. So the issue is, this is absolutely a direct patient benefit and a direct hospital benefit. They can't argue with that. It really is. So you almost got me started there.
Wouldn't want to do that. No.
Now,
just a quick clarification question here. Is it the same form that allows us to appeal on behalf of the patient and then for the ALJ, or is that a separate form? Is there a
the
separate form?
ALJ is definitely the CMS 1696. If you Google it, download it, it's right there. That's really now in our organization, and I think in yours, you can easily do this. You can make them literally form fillable, because you have all the information that would go in there. You just hold off on signature until it's necessary. But the patient will sign it, I can assure you. When you explain, in the event that the federal government or Medicare Advantage plan or your payer doesn't pay for this, this gives us the right to represent you in your argument back to them. So I think it's how you position it to the patient up front in the clinic, pre-surgery, anywhere. This is the missing. This seems to be the missing link between getting patients what they need when they need it, and the rest of it. This is the missing link. And so we're smart people, all of us. And guess what? We're all caring people. We're all in healthcare for a reason, is we want to serve others. And I don't think that the payers are in it for the same reason. You know, their incentives are completely different. So our incentives are pure and true, and we're going to make it happen. So make it happen for your patients.
There's one concerning outpatient surgical appeals. We do a lot of those, and when we've exhausted provider appeals, how do we engage the doctor's office to support getting patient engaged with the appeal process?
Do you mean the surgeon's office or the PCP's office, or? Okay, so outpatient surgery, I get it. So, well, I think there's a number of ways you can do it, right? I believe that your surgeons and your physicians are clearly one of the other big benefactors of setting up a process by which we can appeal on behalf of the patient quickly and effectively, right? They're almost burned out by dealing with health insurance. They, let the hospital deal with it. I don't want to deal with it. Let the patient deal with it. Engaging them, because you need their information to appeal. You need those physician office notes, those pre-surgical therapy notes, all those particular things. It's got to be baked in. So if you can't get them from my chart or from the physician's office directly, I think you have to go to the physician practice leadership and explain how important it is, and that they become a willing participant in this process will save them time, save them angst, and save them money. So.
Have you ever seen a self-funded plan that excludes radiation therapy and chemotherapy from coverage? And have you had success challenging the plan design through the appeal process?
No, I've never seen a self-funded plan that denied those things. When you say, because I believe certain things, there are some there's a couple of technical details, whether it's a grandfather plan or a non-grandfather plan, right? How long has that plan been in place? Whether or not they can incorporate, but you're basically incorporating not prerequisite positions, but conditions that the patient may have had prior to joining the plan, right? And so, but in my understanding, the answer is no. They can't deny specific, as long as they're broad categories of that. So whether it's proton beam therapy or bead therapy, they may declare certain things experimental, investigational, which are definitely winnable cases, if you ask me. And so I think that's one of the tactics they use, is to declare something experimental, investigational, not just say, oh, we don't do radiation therapy, because everybody does, right? But some of the details go into, is it a grandfather plan or non-grandfather plan? But I don't believe even non-grandfather plans or grandfather plans have the ability to deny such a clearly necessary treatment for the conditions that it's treated for. So.
Okay, maybe we'll hit one more of these. Often we notice a delayed appeal response time and then a bump into timely filing, is it possible to send the provider appeal and the member appeal at the same time?
Absolutely. Just the different addresses. Don't send them the same address. So we've done it continuously. So we believe that you should be, like I said, you saw that one slide that had both up there, and that it's, there's a little bit of machination going on, but now with AI and the ability to speed things up and to make things a lot more automated using robotic processing and machine learning, the answer is yes, we can send. I absolutely agree with that tactic. The patient's time frames, the patient levels might be different than the providers. So you have to keep that into fact. It's really creating two different cases because one is going to follow one pathway, one is going to follow another. So two different workflows, but the fact is we've all been working on workflows for the last 20 years in our professional lives, and so we can figure it out. But I absolutely believe you should and could do that, or could and should.
Great. I lied. One more. This might be a good one to end with. Get your insights here. Have you seen more success using the patient appeal process for level of care denials based on the 2 midnight rule for MA plans?
Yes. I mean, to explain it, it's important to identify, midnight by midnight, what the current status is in that patient. But using patient appeals, I think is a something that the payer doesn't necessarily expect. The MA plan doesn't expect that the patient will be appealing. Patients, because if it's the provider appealing the contracted MA plan, they might have one level, maybe two, but the patient has access to the ALJ. And this is whether or not, it's going to sound interesting, but I checked with my friend Eddie Hugh a couple of years ago about this one, about a clinical validation challenges, which are coming back and forth. It's one of the new, one of the denial things that payers have schemed up. But any organization determination, in other words, if a payer changes or deletes a patient's principal diagnosis that the treating physician put on the record, right? And we do have actual documentation that supports that particular diagnosis code, but the payer upholds it anyway. Let's face it, we think that's at the worst, the corporate practice of medicine, and at the least, very appealable because that organization determination is wrong. Patients get to go all 5 levels, providers do not in your MA plans, but patients get to go all the way. And we should have learned by the RAC program that came out all these years ago that once you get to the ALJ, your odds of winning are much, much better than if you're going to have the payer make the determination. We call it, and I know you've all heard this before, getting it outside of the court of the payer's opinion. Okay? I'm steadfast in my belief that they should not be making the medical judgment decisions on behalf of that patient. You as the provider should, not them. They can oversee it and disagree with it and try to say it doesn't exist, but the fact of the matter is that the patient trusts you, not them. So absolutely, patients have greater rights in the MA and in the Medicare world than providers do.
Okay, well, we're just about at time here, everybody. There actually are still a number of questions, but we can follow up with those and send those out to everybody, all the attendees?
Yeah, I'm happy to do that. I probably see my music studio in the background here. I'm not sure if I'm on camera or not, but I want to thank everybody. I would encourage you on behalf of your patients to raise your voice. Whoever asked the question about going to the C-suite, no better time, right, than while senior executives are also screaming about deniers, delayers, and don't payers. And so let's use that to our patient's advantage, right? Let's get this patient appeal thing right. 1% appeal is an absolute travesty. We should be stepping in as advocates in figuring a solution nationally, not just community by community. And we look forward to be a part of that.
Great. Well, Brian, thank you for the presentation today, and everybody on the call. Thank you for joining us.
Hey, thanks. I got a couple of claps there. I guess that's pretty good. All right. Thanks, everyone. Have a blessed day and happy Thanksgiving. Think about others. Don't think of yourself. Think about those in need, because there's plenty of people out there in need. And if you think about it, don't forget your food banks in your neighborhoods and those who are less privileged. Let's do what we can to serve them. Okay. God bless, and thanks for joining.
Take care, everyone.
Thanks. Bye-bye.